Hello, my name is Dr. Wilson Velazquez. I'm a pain and management physician. First of all, I want to give thanks to the Texas A&M Coastal Bend Health Educational Center for inviting me to give this lecture. It's a privilege for me to give this lecture in safe pain management practice, a topic that is very important. I'm an anesthesiologist by training. I did my medical school in the University of Puerto Rico, in San Juan, Puerto Rico. After that, I moved to the Long Island Jewish Medical Center, that's in Queens, New York, where I did my residency in anesthesiologist, and I did my super specialty clinical track in obstetric anesthesia and pain management. I've been practicing pain management for over 20 years. I have no disclosures for this conference. We're going to go through some objectives. We're going to review the most recent 2022 CDC guidelines for pain management. We're going to review some alternative treatment options and multimodal approach for pain management. And we're going to review some safe use of opioid treatment for acute and chronic pain. And you will hear me during the whole lecture, the word safe. We're going to concentrate on the safe use of opioids. It's going to be like a very basic lecture. It's only 1 hour. It's impossible to talk everything about pain and opioids in 1 hour, but I was going to be reviewing a lot of things that you already know. But I'm hoping that after this lecture, you will feel more comfortable in prescribing opioids safely. So let's go through some definitions. We have 3 types of pain. The first one is acute. It's sudden in onset and time limited. Duration has to be less than 1 month. It's usually secondary to some injury, trauma, some medical treatment, others. I'm a very bad handyman. I remember using a hammer and nails in the wood, and I hit my thumb with the hammer, and it got inflamed and swollen and pain for a day or 2 or 3, like in the cartoons, you remember. So that's acute pain. It lasts sometimes days, weeks, but it's way within 1 month, or some patients have certain surgeries and have pain limited within a month. Then you have the subacute pain, and the definition is an unresolved acute pain. So this one usually lasts between 1 and 3 months. And we see this one especially in surgical cases. A patient have a surgery, get complicated, have wound infection or abscess, and they have to go back in another surgery and then prolong the pain for a month, month and a half, 2. We call it subacute, and that's when we see this kind of pain. And the third one is the chronic pain, and that's the one that's lasting more than 3 months, and also result from underlying medical condition. We're going to go through that later, or some disease states, or long-lasting effect of injuries and surgeries and others. We're going to go through some basic statistics. Pain is an universal experience, and it's the most common reason adults seek medical care in the United States. From little babies, when they're 4, 5, 6, 7 months, they start having their teeth coming out of the gums, they have pain. Everybody in their lifetime will have a headache at some point. Ladies that have menstrual pain every month, that's painful. People that work every day, heavy lifting, they complain that the day they have back pain, leg pain. So pain is universal. Everybody will experience pain at some point in their life. I have my experience. I'm doing some sport, playing tennis. I kind of injured my right shoulder, have a torn labrum, and I've been suffering of pain for over 12 years on a daily basis. I don't take opioid for that, but I have pain for many years. It's the most common reason adults seek medical care, and you will see in your practice, primary doctors, nurse practitioner, patient coming to you stating that, "Doctor, I have pain. It hurts. This bothers me. It hurts." Sometimes in my practice, when I see the patient with pain, I get frustrated because a lot of kind of elderly patients, I try to question them about the characteristic of the pain. Listen, tell me, how's the pain? Is a burning pain, an aching pain, throbbing? Tell me something so I have an idea. Doctor, I don't know, it just hurt. So you will hear that a lot. It hurt. So that's the complaint, and we as a healthcare professional, we have to care about that patient complaint of pain. The prevalence, 1 in 5 U.S. adults have chronic pain. So I'm in one of those 1 out of 5 because I have chronic pain. I have pain in my shoulder every single day with certain movement. 1 in 14 adults experience high impact chronic pain. And high impact, as you can see, is highlighted. It has to be most days or every day during the past 3 months that limits life or work activity. So let's kind of mention something about that. High impact pain. My shoulder pain is not high impact. I'm still do things in life. I do my chores. It's not affecting my work. But people that have limitation in their life, they will come to you and say, listen, doctor, I cannot walk, or doctor, I cannot bend, or doctor, I cannot take a shower, doctor, I cannot drive, doctor, I cannot have sex, doctor, I cannot cook, doctor, I cannot sleep. So it's limited their activities of the daily living. And some patient, they limit the work activity. Doctor, this pain, I cannot bend as before, I cannot lift things as before, I cannot go back to work, I have a little small business, I can open the shop. So it's affecting their life in different ways. And then sometimes there are patients, it's kind of a subcategory, patient that the injury or the pain is related to a work, and we have those patients with the workers' comp, the workers-related injury or Department of Labor injuries, and I see a lot of those patients. Sometimes, like we also see patients with accident-related or lawyer cases. Sometimes we have to be careful with those kind of patients because sometimes I'm not sure if they have a real pain or they have a secondary gain. So be careful, treat them, all the patients the same. Pain is very subjective. We need to believe that they have pain, but we have to kind of explore that population and help them accordingly. So remember about high impact pains, important. Okay, let's continue. Why it is important that we treat pain. We're going to be in this slide for a little while. First of all, it affects behavioral health. So that means that the patient is not the same. Patients start telling you, doctor, I feel cranky. Doctor, I feel grouchy. Doctor, I'm irritable. I feel nasty. I'm having problem with my spouse. Doctor, I'm unhappy. I'm whining all the time. And sometimes I refill patients, I get referred from other doctors, and I think that they get upset having a patient whining all the time about the pain. So, but pain is pain, and we have to believe that it can affect their behavioral health. Another reason that it's important that we treat pain properly is because it can affect the mental health. Some patients have pain and they never had depression or anxiety. Now, since they have this injury or this relentless chronic pain, they get depressed because they cannot do the things that they used to do in the past. They get anxiety because of those things. So it's very important because sometimes we treat the pain, but we need to also treat other aspects of their problem, like the depression and anxiety as well. Sleep disturbance. A lot of patients, if you have pain, you cannot sleep. And then they develop chronic fatigue syndrome. They're always tired. They cannot do things. So it's important that we treat pain properly so they can improve their sleeping patterns. Loss of work and productivity, the same reason. It's estimated that annually hundreds of billions of dollars are lost in productivity because patients have pain and patients cannot go to work daily or weekly, or they can open their small business. So loss of productivity, that's a main impact. I kind of feel it's gratifying when I treat a patient with pain and with whatever treatment that we discuss shortly, and then they say, doctor, I'm doing way better. Thank you for the treatment, whatever. I'm able to go back to work. Thank you very much. I can open my business. So that's a good thing. And that's a good feeling. So we as physicians and providers, we need to help our patient in pain so they can go back to work and be productive. Super important that we need to treat pain because a lot of patients will have suicidal ideations. They have the pain can be so severe in intensity or constantly, and they can think about committing suicide. Conditions like very bad cluster headache, the CRPS, chronic renal pain syndrome, to mention a few. And if you see a patient with any kind of this pain and they tell you that I don't think that it's worth living, just a simple thought that they may be thinking about committing suicide, we need to do something. We cannot overlook that fact, and we should refer to an emergency behavioral place or or do something, because it would be sad if the patient commits suicide because of the chronic pain. And not to be the least, a substance use disorder. Patients, if we don't treat the pain properly and they need some treatment, they will look for the treatment someplace else, either in an illegal substance or a prescription medicine in the street to try to get their pain relief. So those are very important aspects that we always have to have in our mind, and that's what we need to treat pain. All of us, physicians, nurse practitioners, providers, pain doctors like myself. So moving on, how to treat pain. And this slide, kind of simple, but I'm going to try to explain to you a concept that I use a lot in my office to how to treat pain, so I can explain my patient properly the logistic of the treatment. What's the plan? There are 3 ways. I tell my patient, listen, there are 3 ways to treat your pain. We can treat it conservatively, we can treat it interventionally, we can treat it surgically. And we're going to go through those examples to follow. So in the conservative treatment of pain, let's start with the physical therapy. Physical therapy is one of the best ways to treat most of the musculoskeletal pain. You have to see the patient for the first time, they fall, they injure the back or muscle or this or that. Send them for physical therapy. It's kind of safe. It resolves a lot of problems. I remember a patient one time, it's an established patient, and the patient have a flare of a pain, and doctor, I want an injection right away. And it was like a Friday, and I told, listen, we need to get it approved by your insurance, those injections. It's not like, let's do it right now. And plus, I leave on vacation and come back in a week, and you have to wait. I'm sorry, let me send you for physical therapy. And then we did that, and when I saw the patient next time, doctor, you know something, I'm doing fine. I didn't need the injection at that time. The therapy helped me a lot. And then, so it's a good modality of treatment. Occupational therapy, amazing tool for patients that sometimes they cannot dress by themselves because of the pain or the injury, or they are not able to walk. They help this patient to be back to be functional. Exercise programs, like going to a gym with a trainer, yoga, tai chi, stretching exercise, tense units, back braces, you name it. There's a lot of modalities, all in the conservative treatment, that they are very good, that we should have this in our mind so we can offer the patient. And I'm going to abound a little bit in the gym kind of trainer exercise program. For my same shoulder injury that I have for 12 years, having pain every day, I decided to join a gym like 4 years ago, and they have like a group trainer, so they kind of guide you to do things. So you start learning about what's a squat, what is a hinge, what's this kind of exercise. So since I've been going to the gym for the past 4 years, I can tell you my experience, I have way less shoulder pain. Before I used to take ibuprofen mostly daily. Now I take it maybe twice a week. So exercise, in my case, has helped me tremendously. So I'm a strongly advocate of exercise programs. I tell my patients, you have to go for exercise. It's going to help you. And they say, doctor, but how can I go to exercise if I have pain? Go, even though you have pain, go through it slowly at the beginning. Force yourself. You see at the end, it will pay off. So strongly advocate for that. Tense units are those little machines that you can offer to the patients, very affordable for muscle pain. Braces are devices that kind of I use a lot in my patient, and it's basically to prevent pain. Doctor, my back is killing me the whole day. Listen, let's try this brace. And they use the brace during the day, and then at the end of the day, they remove the brace, and something have less pain. So it's more of a preventive measurement. So think about all those possibilities when you treat your patient, what to offer them. And again, the concept that I told you, we're going to talk about conservative treatment, interventional treatment, and surgical treatment. So we're still in the conservative treatment. You see that picture of that lady over there? He's in a gym right now. I don't know her age. I guess she's been in the upper 65s or maybe 70s. She's doing something called a bird dog. So I learned that in the gym. That's the position of called a bird dog. So she's strengthening some core muscles in the abdomen, strengthening some muscles in the arm as well, and balance. And she's doing it. So I strongly suggest that you get your patient involved with exercise treatment for their pain, for the chronic pain. If we continue with the next slide, is the continuation of the conservative treatment. Now we're going to talk a little bit about pharmacotherapy. Pharmacotherapy And again, this is a very base lecture. You are all familiar with your medicines, the one that you like to prescribe. I encourage you to keep prescribing safely. Everybody knows the famous NSAIDs, the non-steroidal anti-inflammatory drugs, like your ibuprofen, your celecoxib, ketoprofen, diclofenac, you name it, meloxicam, many, many, many. So be familiar with them, be familiar with the side effects, cardiac toxicity, renal toxicity, and GI bleeding. And sometimes people say, so many people die from opioid overdose, but a lot of people die also from GI bleeding from NSAID. So you have to be careful when we prescribe those medicines as well, but they are safe. Your steroidal medicine, like the Medrol pack, very useful when patient has some flare-up from their conditions, their pain. My pain was steady, doctor, but I have have a flare-up. Prescribe once in a while your Medrol pack for 5-6 days. They work very good on those patients. Have that in your thought in your mind when you're prescribing the acetaminophen, regular Tylenol. You have no idea how many patients that I have that let me give you some tramadols here and there, and the patient said, doctor, that didn't work. You know something, that Tylenol over the counter works better. And in my mind, keep your Tylenol, take it safely. Take less than 6 a day, be under 3,000 milligrams per day, things like that. Remember your neuropathic pain medicines like the gabapentins and the pre-GABA, very useful. You can use it off-label. I've used gabapentin for all kind of pain. I have a patient with hip arthritis, chronic. It's non-surgical, no chance for surgery. We put on gabapentin, no nerve issues, and she loved it. It helped for a joint problem, so you can use it off-label. Muscle relaxant, know your muscle relaxant of preference. I like my tizanidines or cyclobenzaprines or metocarvamol. I don't like Soma. And then you decide what medicine you like to prescribe, know your doses, things like that. For muscle relaxant, I make a little parenthesis. Make sure that when you prescribe it, you tell the patient that they're using because they have a flare-up, some kind of muscle spasm pain. And because a lot of patients in a Burley, because it helped kind of relax the muscle, the patient gets sleepy. Doctor, I taking my muscle relaxant at night, helped me a lot. Lisa, but you have pain at night? Not really, but it helped me to sleep. So you correct your patient, it's not for sleeping aid, it's for pain, for muscle. So be careful because they can get a habit of a muscle relaxant just for sleep. Consider always in your mind having different kind of topical. The most common, the Voltaren. Now it's generic. You don't need prescription for that. Any kind of gel. When you have patient that complains of pain, multiple joints, all the knuckles, both hands, elbows, tell them to use this compounding. There are pharmacies that also do that, and they are very safe. Just make sure that you tell the patient not to shower the whole body with the compounding, just in the areas as needed, but they are safe. And of course, the hot topic is the opioid therapy that we're going to go into that shortly. So you have an idea on conservative treatment, how many things we can tell our patient, hey, do this, do that, the exercise, the yoga, the muscle relax, and this. So you have a bunch of things to discuss with your patient about the treatment of pain, and we're going to talk about opioids in a second. And then I'm going to quickly mention about interventional treatment of pain. Let's start with the simple steroid injection, and you are all providers, you know what you're doing, and there are simple injections in the muscle, the trigger point. You can do joints injections, like the Courbain tendons injections. You can do supraspinatus, you can do hip bursa. They're all very superficial, very simple. There are multiple books that can show you how to do it, or if you're a mid-level, you can tell your physician to show me how you do it, and you learn once or twice, or go online and see on YouTube. But they are simple, safe injection. Just learn the quantities of mLs or steroid, and also learn, of course, any possible complication. But they're safe and superficial, so be aggressive, and those little injections can be done by you. You don't have to send your patient for a pain doctor like me just to do a simple hip bursa injection. But I will do it for you if needed. But then the second part of the interventional treatment is the perispinal injection. That's where we, anesthesiology-trained physician, we do those perispinal injections like epidurals, facet, radiofrequency. When indicated, after we have good imaging and the pain correlate with the symptoms, we do those injections. Now they're kind of outpatient, very, very simple, very guided with ultrasound, very safe for that purpose. I have a lot of patients doing radiofrequency, and it's working very good for those patients for back pain. Diagnostic blocks, teleganglion, you know that, for ophthalmic shingles or atypical facial pain, sympathetic nerve block for CRPS. All those kind of things we do, vertebroplasty when you have some compression fractures, neuromodulation technique, very superficial. Before was only for patients that have back surgery, failed back syndrome. Now we're doing spinal cord for patients that are not candidate for back surgery because of comorbidity or sleep apnea or weight. And now most recently it's being indicated for certain patients with chronic severe diabetic neuropathy. That will be something hopefully approved by insurance, so a lot of patients will benefit. Infusion pumps, cannoneurolysis, and interventional radiology. Depending where you live, check the radiology department where you live to see what they do. They do a lot of things, a lot of blocks, a lot of injection also for pain, guided with X-ray or CT scan, and they have a lot of patients, so don't forget that. So that's interventional treatment of pain. Conservative treatment, interventional treatment. Let's talk a little bit about surgical treatment of pain. So what happened? Some patient need surgery to treat their pain. If the patient have an abscess, the treatment is IND. You need to do an incision and drainage. Otherwise, the patient will have pain. The patient have a hernia in the groin, have pain in the groin, the surgeon has to repair the hernia. If there's a occupying lesion, pressing some nerve, some surgeons have to remove that lesion. So surgeons do a lot of things to help to relieve the pain. People have a fracture, the orthopedic, they fix it, they put plates, screws, they put everything back together. Carpal tunnel is a very simple surgery to release the pressure in the medial nerve. By the way, carpal tunnel is a procedure that can also be injected prior with very good outcome. Patient with severe spinal injuries or pathology causing severe pain, laminectomy, discectomy, foraminectomies, fusion, you name it, SI fusion, a lot of things that surgeons, different kind of surgeons can do to relieve pain. One thing that I mentioned about surgical treatment, the surgeons are doing awesome job, but it's a blade, it's a scalpel, so it's more aggressive than maybe an injection or other treatment. So we have to go in that logistic panel, or listen, let's try something more safe, and then possible injection, possible surgery. But if the indication of surgery is immediately, the patient goes directly for surgery, and they solve the problem. In my personal experience, I have a bunion problem many years ago. So I couldn't put my shoes, so I went to a surgeon, and he cut the skin, he removed the bone, he cut my bunion, he fixed my problem, I can put my shoes, happy. But since then, I live with my big toe is numb, especially when I'm driving. So I kind of look at it, I check it out, but it's numb. I end up with something that I didn't have it. A problem was fixed, but I have another issue. So that happens sometimes with surgery. That's why we have a syndrome called failed back syndrome from certain surgeons. The patient develops scar tissue and they develop this problem. But it's a modality of treatment, surgery. So we can treat it conservatively, we can treat it interventionally, or we can treat it surgically. So know that you know that way to treat pain. Let's start talking about the hot topic, opioid use. And you see in parentheses, I use the word safe use. Why? Because opioids are very risky, and everybody hear about the opioid epidemics and how many people die in this nation from opioids. So we, physician or providers that treat pain with opioids, we need to do it safely. We can use opioids for acute pain, we can use opioids for chronic pain, and we can use opioid for cancer pain. I will mention that for cancer pain, yeah, we are maybe more, let's use the word more, have more leverage. We can be like prescribing more because it's cancer, and the patient have cancer, so we can go in higher dose, things like that, and that's fine, especially in advanced stages of cancer. But we have to be careful. I remember one patient that moved from another state and came to my office the first time, and she told me, "Doctor, I'm here because I'm a patient of cancer. I have breast cancer 3 years ago. I have my surgery." And they're okay. And listen, and you went through chemo? Yeah. You have cancer right now? No, I'm in remission. I'm cancer free. I'm in remission. And then the doctor in that state was prescribing like 180 pills of an opioid. And I, in my mind, well, you have cancer, or you have the diagnosis of cancer, but you have no cancer right now. Let me work with you together. I think that you're taking a little bit kind of high dose, and let's see if we can restructure things, because I don't think it's safe That was my assessment, and we did some changes. So if the cancer is a stage 4 and the cancer is eating those bones and it's already metastasis, that's a different case. But be careful when they just bring with a diagnosis of cancer, and B, you should use your judgment to treat that pain accordingly but safely. Let's go to review a couple of things that you know. This is kind of a quick slide. Opioid classification. The Schedule 3 formulation, your tramadols, the codeines, number 3 and number 4, the Tresix, Butrans, buprenorphine, Belbucas. We have the Schedule 2, the hydrocodone, oxycodone, morphine, methadone, the tapentadol, Nucynta, fentanyl. And you have your extended release tramadols or high singlet hydrocodone extended release, extamsize, oxycodone extended release, Nucynta ER means extended release, and your morphine. So we all know opioids, and that's a few. The list can be extensive. There are all the opioids that can be included. You get when you decide to prescribe your opioids, get familiar with your opioids, how to use it, the dose, the frequency, things like that. In my case, I educate my patient. I don't like when they say, I'm taking Tylenol. Yeah, but Tylenol what? Number 3. What 3 means? I tell them, you're taking codeine. The Tylenol, you can take Tylenol over the counter if you want. I'm prescribing you codeine. And the 3 means 30 milligrams, the 4 means 60. You need to know what you're taking. It's an opioid. How many times patients have been in medicine like hydrocodone, and all of a sudden, you know that you're taking something that comes from the opioid, like the plant, the same plant that you can have some heroin. Are you saying that I'm taking heroin? No, man. It's kind of, this is a legal heroin prescribed, but yeah, it's kind of similar. It's risky, it's dangerous, and some patients, they even know what they are taking, so we need to explain them what they're taking, what an opioid means, and things like that. We're going to go through that in a second. But it's important that you know all this, because sometimes when we're prescribing an immediate release formulation of either hydrocodone or oxycodone or even tramadol, and we see that the patient is developing like a ceiling effect, like, doctor, you prescribed 2, is not enough, so let's go to 4. Doctor, is still on pain, let's go to 6, and then from 6 to 8 to 10, that's called ceiling effect, kind of can go to 12 if you want. No, that's not good. So then you have the option, listen, we cannot prescribe this big, huge amount of opioid, immediate release. Let's start working on an extended release as a main opioid, and then we give you some few for breakthrough for those days that you do something extra, or you do the jar, or you do some vacuum for breakthrough pain. So we need to explain those things to the patient, not just keep increasing an immediate release because it's not safe. And the purpose of this conference is to learn to do safe opioid treatment. Still a C2, still, yeah, you have to do your homework, but it's a good idea to sometimes use the extended release formulation. These are one of the guidelines. There are many guidelines. There are in pages and pages, but I decided to take a few so we can learn something in this hour. This one says, when diagnosis and severity of acute pain warrants the use of opioids, clinicians should prescribe immediate release opioid at the lowest effective dose and for no longer than the expected duration of pain severe enough to require opioid to minimize unintentional initiation of long-term opioid use. So a couple of things that we need to digest in this slide. It says here that if we decide that the patient needs should be the lowest effective dose, and it says no longer than the expected duration of time. So who decide who was the lowest expected dose, and who decide was the expected duration of pain? We don't know. Why? Because we all wired different. We have different pharmacokinetics, different pharmacodynamics. I have a surgery, I have hemorrhoid surgery, and I took opioids for 3 weeks. And my son have a similar surgery, hemorrhoid. He took opioids for 1 week. So that the expected of time for him was 1 week. For me, was 3 weeks. The lowest dose, yeah, we need to try to the lowest dose, but it can be 2 pills a day. It can be 4. So when you dialogue with the patient and you make the assessment, listen, I'm going to give you this for this acute pain, severity of the acute pain. You try the lowest possible and the lowest that you feel comfortable. If it's 2 pills, 4, and then you reassess the patient, and from there do the proper decision. So, but the important of this slide is that, yes, it had to be the lowest, the better. And I like one of the rules that was changed at some point a few years ago is that for acute pain, pharmacists are now supposed to prescribe or to dispense only 7 days for acute pain. I kind of like that. Surgeons do their surgery. And they prescribe their opioids, and that maybe the patient just need a few pills during that 7 days, and that's fine. And they resolve the problem, and you avoid having a long-term use of opioid, using opioid for month or year. So I kind of like that rule. And in that slide, you can see the last part says to minimize unintentional initiation of long-term opioid use. We as a healthcare professional, we make an oath of no harm. So I won't imagine that there's no doctor that kind of would like to cause that their patient be a opioid user or opioid addicted to opioids, things like that. So it's not unintentional. It's not with intention that the doctors or we are doing those things. But if we don't care and we don't pay attention, it can be unintentionally put a patient on a long-term opioid use. I really remember an example of a surgeon that came to me many years ago, and you remember also this old school that we need to treat the pain as the fifth vital signs, and then so we need to treat pain. Patient kind of suffer, and this surgeon did some knee replacement or knee surgery, and patient was in pain, so the surgeon started prescribing the opioids to 120 pills per month to 180. And next month, still on pain, he refilled that month and after month. And I remember a surgeon prescribing high dose of immediate release opioid for years. So he did the surgery, but unintentionally the patient became a long-term opioid use. So we need to be paying attention to that. Sometimes I feel that my job as a pain doctor is really, I get that kind of patient and I work with them to get you out of the opioids. And it's also very gratifying when I see a patient that was taking 8-10 immediate release hydrocodone or oxycodone, and when we work together doing some changes, opioid rotation, the patient is taking less amount, still with the same pain, same intensity, but with less opioid, and it's a good thing. So we need to rotate medicine and think about the lowest dose and for no longer than the expected duration. And that's one of the guidelines. So we need to follow the guidelines. Then this one also, let's read it. Clinician should consider concurrent medical conditions, including sleep apnea, pregnancy, renal or hepatic insufficiency, mental health condition, and substance use disorder in assessing the risk of opioid therapy. What it means with this one, it's no-brainer. If you have a patient and complaining of pain and the patient has sleep apnea, we have to be careful. One time, remember, a patient came to me. He's kind of in the chubby side. That doesn't mean that all people are obese have sleep apnea, but he had sleep apnea diagnosed, and I was talking to him doing my interview, and you cannot believe that in front of me, I was talking and he fell to sleep snoring. Can you believe if that patient I prescribed some opioid, most likely he will stop breathing and it will be a mess. So see the clinical condition, and that patient is not a candidate for an opioid. That will be detrimental for him. Let's try other route. Let's try from the conservative treatment, the NSAIDs or other things, or the exercise program, other route. But be careful with the opioids for patient with sleep apnea. Pregnancy is not it's not bueno for the baby. So pregnancy usually they have to deal with some acetaminophen, kind of safe, and usually obstetricians are very good at treating the pain while the patient is pregnant. I have patients that were in opioids, let's say for rheumatoid arthritis, they get pregnant, and then immediately we stop the opioids, and they did extremely well with just Tylenol during the pregnancy. So be careful. Renal, hepatic insufficiency, no-brainer. You do adjust the doses. You are expert in doing those things. Mental health conditions, super, super important. When you see a patient that's been diagnosed with the bipolar depression or the schizophrenia or schizophrenia disorder or any of those, don't prescribe opioid. Or if you do it minimally for a short period of time. They have a very high addictive personality. They are high risk. They are already in antidepressant. They are already in anxiolytic and benzodiazepine, and you add an opioid, and that mixture can be very detrimental and very dangerous. So be careful with this population of patients. Patient with substance use disorder, patients already using what we call in the state illegal high dose of cannabis or cocaine, meth, all those things, no-brainer. They are high risk of, if you prescribe an opioid, putting in high risk plus, sincerely, most of them, they want you the prescription so they can sell it, so they can buy what they like. So be very, very careful with those patients. But you have to use this assessment of those kind of patients in assessing the risk of the opioid therapy. Super, super important. Patient education and discussion before starting outpatient opioid therapy are critical so that patient preference and values can be understood and used to inform clinical decisions. Clinicians should ensure that patients are aware of expected benefit of, common risk of, serious risk of, an alternative to opioids before starting or continuing opioid therapy, and should involve patient in decision about whether to start opioid therapy. Imperative that we do our homework. We need to talk to our patient, explain things. I see a patient, I do my proper history, what I need to know about pain, location, distribution, characteristic, all those things. I do my physical exam pertinent. I tell that patient, listen, I'm not going to put a stethoscope in your chest, so I'm going to write that you have no murmurs because I'm not listening to your heart. I can write that you have no distress because you're not breathing labor. I'm going to examine what I need from your back, your flexion, extension, reflex, strength, all those things. But the majority of the time in my visit with my patient with opioids is explaining. Listen, this is the risk. This can happen. You can have this side effect. You can die. You can stop breathing. You can get constipated. And it's only for you and you only. You have to bring the bottles all the time. We have to explaining. And the risk. And then we have to get the patient involved in the decision. I remember a patient that came to me, and he said, Doctor, when I went to this physician, I'm complaining of pain. Immediately they put me on 2 of the oxycodone, 30 milligrams ER in the morning, then 2 in the afternoon. That was 4, and then for breakthrough, like 3 during the day, of the 40s, and then you start doing the math, and those patients that were getting 380 pills per month, 420 pills. I'm pretty sure that you remember those days of those high dose prescriptions. And the patient said, I was told to take this way. I was not given the option of deciding. And really, when I saw this patient, the patient was looked like a drug addict, very somnolent. They were very foggy. They don't understand, memory loss and impairments, and a disaster. So we need to get the patient involved and listen, I can help you with this medicine. We started low dose, but you know the risk, and you're okay. And in the same token, we have a patient recently that referred to me for treatment, and then something in the back. I examined the patient. I reviewed the imaging. Listen, we can do this injection. We can do this and that. What do you think? I thank you, doctor. I appreciate that. My doctor sent me to you as a pain management doctor. And I was afraid that you were going to start me an opioid, and I don't want opioids. So listen, man, we're not here to prescribe opioid only. We're here to help you. So you have to have this discussion with the patient about risk, alternative treatment, and the decision has to be with the patient. And I go beyond that. If the patient is kind of an elderly, get the family involved. You tell, ma'am, sir, next time bring your daughter or son, please. I would like them to be here with you so we can share all this risk. Some patients, they don't remember and they can make mistake how they take the medicine at home. So it's super important that we explain things and remember, involve the patient in the decision. All right, let's keep going. What is essential to educate and discuss? We need to tell them that we start short term, but if we're not careful, we can go in long term. You can be on opioids for months or even years. Tell them that we're going to work toward a planned discontinuation of opioid and opioid use as soon as feasible. So as soon as we can taper them down, we're going to do it. Advice about serious side effects, fatal respiratory depression, development of opioid abuse disorder, and the side effects. And we have to mention about the development of opioid use disorder because it's like any other abuse disorder. If you drink too much alcohol, you get alcohol abuse disorder, you're alcoholic. If you use any drug, cocaine, heroin, you are in a drug use disorder. If you take too much carbohydrate, you're carbohydrate use disorder and you are obese. And the same thing with the opioids. You can develop an opioid use disorder. And that doesn't mean that the patient is an addict. You don't label the patient an addict. An opioid abuse disorder can be that you told the patient, listen, it's going to be 3 a day take 3 a day, and the patient take 5. Doctor, it was a very bad day, I took extra, and then, so we need to talk to them about, no, we don't want that because this can escalate and the risk. So we need to discuss that, that's essential. And of course, mention all the most common side effects and treat it accordingly. Half of the patient, 40% of the patient on opioids get constipated, so ask, listen, are you constipated? Yes, okay, let me help you. There are plenty of medicine that are uniquely designed for the opioid-induced constipation. Use them, help the patient with those symptoms. All right, so we're in the topic of opioids, so we need to do it safely, correct? So we have a bunch of tools that will help us to prescribe properly. And I know that you know all those things, but I just need to go through so you can refresh things, and I want you to feel more comfortable doing your job as prescribing opioids. The Prescription Drug Monitor Program, or PDMP, I call it PMP. By law, is highlighted, by law, physicians are now required to set up an account with the Texas PDMP and check the PMP prior to prescribing opioids, benzodiazepine, barbiturates, and the SOMAs. The Prescription Monitor Program does not specifically fall under HIPAA, but prescriber, you and me, and dispensers are. What this means, you use the DMP only for your patient. You cannot check the PMP from your neighbor, from your spouse, or other persons. That will be a HIPAA violation. Do it only for your patients. It's a valuable tool. I use it every day, and it's just a click away. You can set up your EMR that is just a click away. If you feel that that's inconvenient, you can assign a medical assistant and delegate to an authority, and she can download the PMP for you. So when you see the patient, it's already in your chart. I use it all the time. I use it for new patients. I'm going to see a new patient for the first time. And then before going to the room, I check the PMP. And then I have an scribe. Her name is Sean, so we go together, and she write the note for me. And then I check the PMP, and I say, Sean, this PMP is... There's going to be a fight here, because I see in the PMP for the last 2 years, patient having prescription of high amount of opioid for month after month, the same medicine with no change done, and then say, well, let's see what we're going to find over there. There's going to be a fight. I tell my assistant. And the same token, then I see a PMP in a new patient with some tramadol last month and some codeine last year. Sean, this is a benign PMP. There's nothing to worry. Let's go over there. But sometimes I'm wrong. I see that patient with a PMP with a lot of opioid for month after month, and when I do my history, my physical exam, the patient have an advanced rheumatoid arthritis with deformity, all the hands and finger, all deformity, all crooked, a lot of pain. So I'm pretty sure that you need it. It's working for you? Yes, doctor, this regimen is working. I'm functional. I can do things, and help me, please. Then, so I was wrong in my initial assessment, just looking to the PMP, but it's valuable. Use the PMP. It will help you to prescribe safely. And then, again, you can set up your EMR just a click away. But remember, it's the law. You have to do it. It's the law. You have to do it. And besides, in the PMP, looking for opioid, look for other things like Ambien, Zolpidem, any benzodiazepine, barbiturates, other psychiatric medicines. So that will give you an idea also what kind of patient we're dealing, things like that. All right. Then this is how kind of the webpage looks like, where you can register, you can log in and do all those kind of things. And again, you can assign somebody. And in my case, in my EMR, it's designed that when I am seeing the patient in the room and I open the encounter for that day, it's a click away. And sometimes I use the PMP to show you, listen, man, let me show you. This is the prescription that you got this month. This is the prescription or this. And I discuss with them, showing what they're getting. Sometimes when they get something from other physicians, I show them, listen, what happened? I went to the dentist. I have done that procedure. Okay, we explain that one. So use that tool. It's very valuable. And it's easy. It's just a click away. Then toxicology testing. We're supposed to follow this for when we prescribe opioid. It can be either UDS, urine drug screen, can be blood or saliva, especially patient with on dialysis. or the conditions. So use the company that you want, that's fine. But we have to do it. Toxicology testing should not be used, and this is one of the guidelines, it's another point from the CDC guidelines. Toxicology testing should not be used as a punitive manner, but should be used in the context of other clinical information to inform and improve patient care. Testing is intended to improve their safety. It should not be used to dismiss patient from care. Discuss an unexpected result in a non-judgmental manner. Avoid stigmatizing terms like dirty urine or it's not clean urine, things like that. Another valuable tool, we need to do this, is a part of our homework to prescribe opioids. And then I use it in concomitant with the PMP. I see a patient in the day of the evaluation, I'm prescribing opioids, and I tell, listen, how's the medicine working for you? Good. How you taking? I prescribe you 90 pills, so 3 a day. Yes. So listen, you took it today? No, I haven't taken it today. What about yesterday? No, I didn't take it yesterday neither. So when was the last time you used it? Like 4 or 5 days ago. So listen, so that means that you're not using 3 a day. And if we do the urine test, it's going to be negative. So maybe you don't need 90 pills a month. Let me change it to maybe 60 or 30. And you do things accordingly because, you're assuming the patient is taking as needed. But if they don't need it, you always try for the lowest amount in the most safe way to prescribe opioid. So use your PMP, use your urine testing. It will give you valuable information about if the patient is using what you are prescribing. It will tell you if the patient is using something that you are not prescribing in terms of opioid, or if they are using other substance. But use it to explain, don't condemn the patient, don't be mad with them. Give chances. One patient for many years doing 2 urine tests a year, everything normal, consistent with prescription, very stable patient, 2 or 3 years. All of a sudden, I have a UDS positive for THC. So I see this nice old lady, and in my mind, I don't think that she's smoking weed, but I talked to her, and she was using some CBD thing from a family that they gave it to me. And I told man, so listen, it may be safe, but unfortunately, here that's an issue with that, and try to abstain, don't use it anymore. She said, don't worry, doctor, I don't use it anymore. We repeated later, it was negative. So things like that. So just one thing, don't kind of dismiss or get mad, just get the explanation, explain the patient the risk, and keep forward with the proper treatment. And remember, labs are run by humans, and with humans, we make errors, so there will be a lab error. Just repeat it. I'm not sure that. Let's do it again and see what happened and do your assessment with your. But it's imperative that we do our homework of checking the PMP, checking the toxicology. This is an example, so it sometimes comes in 1 or 2 pages, and you can see that it will give you consistent results. In this case, I was a patient using some Tylenol with codeine, and then some tapentadol, and there's a bracket for inconsistent results. And sometimes the patients show a clonazepam, and they didn't tell you that we're using clonazepam, even though you don't prescribe it. So keep a look to the whole scenario. The next page, you can see the other things in that we're looking for: antidepressants, benzodiazepine, the cannabis, gabapentin, the different kind of opioids, and that's the third page of this. Usually will be green when it's what you prescribe. It usually will be a red, that you can see red. Let me see that this red was for, and it's because it's something that was not supposed to be there. Address it with the patient. Don't overlook the last one. It says alcohol. Patient that you prescribe good, hefty dose amount of opioid, they shouldn't be drinking excessively. And I've caught a few of those ones and said, listen, this is not good. Alcohol and opioids. And then on top of that, you take a benzodiazepines at the 3 no-nos, you can die. It can be lethal. You can die. So either you cut your alcohol consumption, or I have to cut your opioids. So see the whole scenario. So an amazing tool that can help you to prescribe safely the opioids of your patients, PMP, and the urine analysis. Then next one here talks about the MME. When you open the PMP, it will give you an idea also the MME. You can calculate it using this graphic, or there's some apps that you can have in your phone, or just the PMP will tell you how many, the amount of morphine milliequivalent. So somebody designed this, one of those boards, and can kind of help because it can give you a guidelines of what's the limit of safe opioid, and kind of right now I think it's in the 80 MMEs. And then when we have those patients I mentioned before that they were taking 380 pills a month or 420 pills a month, those MMEs were in the over 200, things like that. And then we went to 80 or less. But this is not an absolute rule. I have a good patient. He is working, he's functional, he's productive, he has multiple back surgeries, he's on some opioids that I prescribe, and all his urines are being consistent with no illegal substance, perfect patient, and he's in 120 MMEs. So I'm going to keep it like that. As soon as I document everything and the patient is doing well, there's no reason why I need to listen. I need to go you less than 80 because you use your judgment and talk to the patient as well. But it's okay. But I can tell you for now that the majority of my patients are way, way less than 80. And that's because once you explain the risk and the treatment, they are taking 1 or 2 tramadols or 1 extended release or 1 or 2 hydrocodone, 2 or 3 pills and an injection and this and that, and they're happy, they're functional, way under 80. But that's another thing that you can use, but everything has to be documented. So how does all this information come into play in your decision-making in safe opioid use? Well, you are a physician. You are being trained to do your comprehensive evaluation that includes your history and your physical exam, pertinent testing. I'm blessed that when I get a referral, it's already done. They come with the imaging, X-ray, CAT scan, MRIs, all those things. The diagnosis is made. You check your PMP, and then you review the notes. When I receive a referral, I go thoroughly through the notes to see what's going on with this patient from the perspective from the PCP or the other pain doctor or surgeon, and that gives me an idea what to expect, how to treat the pain. And I also get the family involved, and then you make an assessment. And I say, yes, ma'am, or ma'am, sir, ma'am, you may need opioid. You want it, and you make your decision of safely prescribing your opioids for this patient. And some example of condition that can precipitate a chronic pain syndrome, that the patient is on chronic pain for years and years and months and years. Some examples are the autoimmune disease, like the rheumatoid arthritis. I have a lot of patients with lupus as well, and they have chronic joint pain, shoulders, elbows, hand, knuckles, knee. The psoriatic arthritis, another one. Advanced degenerative joint disease, very common. After I tell the patient, listen, man, after 50, we're going down. That's nature. We will have degenerative changes in the disc, in the joint, and that's painful. The painful osteoarthritis syndrome, advanced degenerative disc disease, condition caused by trauma. I see a lot of patients with CRPS, chronic regional pain syndrome. It used to be known as the RSD, reflex sympathetic dystrophy. Phantom limb pain is a real sympathetically mediated pain. Central pain syndrome from traumas, head trauma, multiple things. Condition caused by surgical treatment. Surgeons they do their best, but I get referral. I have ankle surgery and I have CRPS in my right ankle. You can have CRPS from hernia surgery, from bunion surgery, multiple things, and we need to treat those patients accordingly. Failed back syndrome, we see that a lot. There's a patient that after the back surgery, they fix certain things, but they develop scar tissue in the inside and continue with chronic low back pain, leg pain, sometimes devastating pain. So we help a lot of those patients as well. Cancer with advanced stages. And it's super important that we treat it accordingly. And if it's really very, very, very advanced, there's much that you can do from office-based practice. At some point, you tell the patient, listen, I think that you should be on hospice, and they will take care kind of on a daily basis your pain needs. Condition caused by radiation therapy or chemotherapy and others. So there's a lot of things that can cause pain, and a lot of conditions, as you can see, that we can treat it. And again, can be conservative treatment, interventional treatment, or surgical treatment, and we can treat it with opioids. And if we're going to do it, it has to be in a safe way. That's the title of the conference, Safe Pain Management Practices. And you can do safe pain management. There are not too many pain doctors, especially in South Texas, so we cannot see all the patient in pain. So PCPs, primary doctors, internists, gastroenterologists, you treat your patient, you can do it. You can prescribe opioid safely because sometimes they need it, and again, it's gratifying when we see the good outcome of this patient. So sometimes I see patient referred by primary doctor, and the patient was taking just 2 tramadol a day. I said, I really don't think that you need to be here, man. Your doctor should be able to do that, but I will do it gladly. But again, if it's a simple opioid therapy, don't feel bad. It's not difficult to do the homework, the PMP or UDS, do it and keep those patients. This slide is from one of my patients. She had some fracture, I think it was C1 or C2. That's the same fracture of the Superman actor Reeves or something, that he was paralyzed in a wheelchair forever. This lady, the surgeon, intervened on time, and he did his magic. He fused all the vertebral bodies of the cervical spine, and then she's walking, in a walker, but she's walking, and she's breathing, and kind of fused the back. And this patient, every day, tell me, doctor, I have a headache. And can you imagine why she have a headache? She has 3 nails or screws in the skull over there. Imagine when she put the head in the pillow. I think that should be very painful. I'm working on her right now, prescribing some opioid very safely, super nice lady. And I tell her, listen, man, do my best, and sometimes take this medicine, fine, let's do some therapy, or find a way in that algorithm that I show you about conservative, interventional, surgical. In this case, she already had the surgery. Says, no more surgery for you, man. Or I tried my injection didn't work. There's no more injection for you, man. Let's concentrate on helping you with a safe opioid, or this patch, or this extended release, or this NSAID, or this therapy. But we need to talk to them, help them, because you can see this lady needs help for sure, and I would do it gladly. Takeaways. All healthcare personnel, including but not limited to physicians, nurse practitioner, physician assistant, pharmacists, physical therapists, registered nurse, and medical assistant, are important in the care and treatment of patients suffering with chronic pain. And this is important to emphasize the word care. Patient needs someone to listen to them and to understand their painful situation they are dealing with. With these guidelines and tools, we should be able to safely treat and prescribe medication, including opioids. When I say to emphasize the word care, it's that we are healthcare professionals, and we need to care. The patients, sometimes they just need somebody to listen to them, the complaints. And if I might would say, this is a whiner, I'm not helping, let me listen to you, let me see. And do it properly and in a timely manner. Sometimes we need to spend our office busy, but listen to the patient. They need somebody to listen, that they understand. Involve your team. I have my medical assistant and receptionist. Everybody that come here, you're going to treat that patient like it's your mom or your dad or your spouse or your children. The way that you want them to be treated, you're going to treat my patient. Always put a smile in your face to everybody. Good morning, good afternoon, have a good day. And then we create like a little family. We are like a little family over there, and patients that get involved with them know them and respect them, and you would know them as friends sometimes. And listen to them. Sometimes I pray with my patient. I know them. They bring me goodies and cakes or things like that. Sometimes they try to bribe me. They try to bribe me to increase the medicine, bring in some good cheesecake, but they fail. But it's a good thing to treat pain with opioids safely, patient benefit. It's gratifying for me to do what I'm doing, and I'm planning to keep doing as much as I can to help a patient in pain. I think that I've concluded my lecture. I give thanks again to Texas A&M and for the audience that have been listening to this conference, and I hope that you learned something today. Have a good day.